Saram, dear brothers and sisters. Welcome to today's healthcare webinar on facial pain, presented by Dr. Bhaskar. Dr. Bhaskar graduated from the University of Madras in India. He did 1-year fellowship in rhinology at Melbourne, Australia, and has been practicing consultant since 2002. Dr. Ram is a consultant otolaryngologist at the Aberdeen Royal Infirmary in Scotland, with special interest in rhinoplasty, advanced endoscopic sinus surgery, otology surgery, dizziness management, facial pain management, chronic cough management, and immunotherapy. Dr. Ram is the course director for the Scottish ENT Update course, Facial Pain Symposium course, Practical Management of Allergy, and Management of Difficult Airways. Dr. Ram has been a devotee of Bhagwan Sri Sathya Sai Baba for many years and is currently Region 8 President. He has been fortunate enough to work and carry out ENT surgery at the Super Speciality Hospital in Prashanthi Nilayam for the past 8 years and has been blessed to go to medical camps in several countries with Dr. Upadhyaya. I will now hand over to Dr. Bhaskar Ram for his presentation. Thank you, Sai Ram.
Sai Ram to all of you. My name is Mr. Bhaskar Ram. I'm one of the ENT consultants working at Aberdeen Royal Infirmary, University of Aberdeen in Scotland. I would like to thank Dr. Upadhyaya, Gayatri Madam, and Santa Madam and Session for the kind invitation and also for helping with this broadcast. I've been asked to talk about facial pain, and what I'm going to do over the next 30 minutes or so is to talk about the how common the facial pain is in the community, then go through some of the causes for facial pain, and I will illustrate with some examples so that it will register better. Session, can we go to the next slide, please? Okay, so this is the Bonnie, Scotland, and we have the wonderful golf courses in Scotland. And those of you who are living in England, you're very welcome to come down and enjoy lovely golf courses in Scotland. It is rich in oil, and the oil prices are going up, so that is good for Aberdeen in a way, but it's not good for the economy for the people. If we had a famous Balmoral Castle where our wonderful Queen used to visit, but probably now King Charles will probably come more to Balmoral Castle. It's got lovely beaches, but it's too cold to go into the water. Next slide, please, Station. There is no conflict of interest. Next slide, please. Right, as I said, we'll go through some other causes for facial pain, look at some treatments that we commonly use for facial pain, and finish off with an algorithm of how we diagnose facial pain. Okay, next slide, please. Now, when we say facial pain, there is a significant overlap between headache and facial pain. A lot of patients come to me saying, "Doctor, I've got this headache over my forehead." And some patients say, "Doctor, I have a lot of facial pain over the face." And as you can see, there is a significant overlap between the two. Next slide, please. Now, if you look at the facial pain, how common is it in the community? If you look at the incidence, the overall prevalence is about 26%. That means almost 1/3 of the population would have experienced facial pain at one time or another. And if you look at the common causes of facial pain we see in the community, the most common ones are migraine, temporomandibular joint dysfunction, which is like a jaw joint dysfunction, and sinusitis. And there are a few other rare causes. Next slide, please. Now, let us start with the case scenarios. Now, here is a 54-year-old patient who comes to the clinic with a nasal blockage, nasal discharge, and some pressure over the right side of the face. So even from the history, you know that this patient has got sinus problems. And when you look inside the nose, you will find some swelling and discharge. Next slide, please. So this is what you see when you put a camera into the nose. You will find a lot of swelling inside the lining of the nose, and it is no brainer, and anybody could have made an easy diagnosis that this patient is suffering from chronic sinusitis. Next slide, please. When you look at the definition, when you coin somebody to say that you have sinusitis, they should have nasal blockage, they should have nasal discharge, they may have facial pain, they may have loss of smell. And in addition to the history, it should be substantiated by an endoscopy of the nose, where you should see pus in the nose or polyps in the nose or some discharge. Then you can say that this patient has sinusitis. Okay, next slide, please. Now, there is a very interesting study in Europe. They put in an advert in the paper and they said, anybody who thought they had the sinus headaches, please come and see us. And when they examined them, it was very interesting to see only 3% of these patients who thought they had sinusitis and sinus headaches were actually having sinus problems. So that is a very interesting study. Next slide, please. Now, there is a professor in Nottingham called Professor Nick Jones. He does a very tertiary clinic, and he has a very deep interest in managing facial pain. So he looked at almost 1,000 patients of his in his logbook, and he runs a special facial pain clinic, and he gets referrals from all over Nottingham, and he looked at these patients. And he said, how many of these patients actually have sinusitis? Because they were all referred for sinus problems. Only 11% had pain that could be attributable to the sinusitis. And then he analyzed that the most common cause for facial pain in his 1,000 patients was migraine, tension headache, cluster headache, and mid-facial pain. Next slide, please. Now, the professor again said, okay, what about those patients who actually have sinusitis? That means they have nasal blockage, nasal discharge, and some pressure. And when he looked at these patients, almost 108 patients, he found that out of these 108, only 25% or 1/3 of these patients who are proven to have sinusitis because they had pus and polyps, these people had facial pain. So only 1/3 of chronic sinusitis patients have facial pain. So next slide, please. So there is a message in the first scenario. Not all patients with chronic sinusitis have facial pain, and facial pain is not a common feature of sinusitis. So that is the first message I would like to drive. Now, without further ado, we'll go to the next case scenario. Here is a 71-year-old patient who comes with severe right-sided facial pain. He puts his hand over his cheek and the jaw. The pain is very sharp. It is like an electric shock like pain. It goes over the cheekbone, the jawbone. And the pain is so severe, it is triggered by eating, talking, touching a spot on the right side of the chin, also while shaving. So the pain is excruciating, but it is very brief. It only lasts for a few seconds, and it keeps coming back again and again and again. So the dentist says, I don't think it's a dental problem. They do a brain scan thinking it might be a tumor. That's also normal. So next slide, please. So when a patient develops a very severe pain, it is like an electric shock, very sharp, radiating, lasting for a few seconds over the jawbone. The most common diagnosis in these patients is trigeminal neuralgia. It is a condition where there is some irritation of the trigeminal nerve or inflammation in simple terms, and that causes this shooting pain. Okay, next slide, please. So if you look at the common causes, why do these patients get this pain, the shooting pain, the electric-like pain? One of the common causes is a vascular compression. So this is in the brain where the nerve takes off from the brain into the face. At that point, you have a blood vessel and the nerve. Sometimes the blood vessel can press on that nerve. The blood vessel's name is called AICA, A-I-C-A, and that vessel can press on this nerve and cause trigeminal neuralgia. The other causes are multiple sclerosis and very rarely tumors. Next slide, please, Station. So how do we treat this condition? Now, the first treatment will be medications. Station, can you go to the next slide just for a second? And then the next slide. Okay, so we'll go back 2 slides again, please. Thank you. Yeah. So the first treatment, if you see a GP for trigeminal neuralgia, he will give a medication called carbamazepine or oxycarbamazepine. Okay, that is the standard drug that we use. If you don't get better with that, the neurologist will speak to the neurosurgeon and we will use some interventional procedures like balloon compression or radiofrequency treatments and gangliolysis. That means we bust the ganglion. So these are some interventional treatments. They are minimally invasive. You don't need a big brain operation for this, but these are minimal interventional techniques we use if you don't get better with the carbamazepine or oxycarbamazepine medication. Next slide, please. In a very severe case where you have tried carbamazepine, you have tried this gangliolysis, and if your MRI scan shows the blood vessel is pressing on the nerve, then you would require a brain operation where we open the brain of that particular part. We identify the trigeminal nerve, we identify that curved red blood vessel, and we separate the two by putting in some pledgets so that it doesn't press on the nerve. So this operation is called microvascular decompression, basically separating the blood vessel from the nerve. Okay, so it doesn't press on that. In simple terms, that is what it is, but it requires a brain operation or a craniotomy operation. So this is the treatment for trigeminal neuralgia. So in summary, trigeminal neuralgia is sharp electric-like pain radiating across your jaw. The treatment is medication with oxycarbamazepine. If you don't respond, you have minimal interventional techniques or you require a brain operation. Next slide, please. So now let us look at this case. Here is a young girl, 26-year-old, with a facial pain, headaches, some tightness in the neck, and within 1 hour of getting the pain, she starts developing nausea, photophobia, that means sensitivity to light and sound and nasal congestion, and she has to take a lot of painkillers, and the headache really lasts for 2 to 3 days. So again, a lot of you already know the diagnosis. It is a classical case of migraine. So next slide, please. So that is what you see. So a young girl or a young patient who comes to you with headaches, nausea, vomiting, and sensitivity to light, it's a no-brainer. It is due to migraine. Next slide, please. Now, to coin somebody to say you definitely have migraine, then they should have at least 5 attacks. The pain should last for 4 hours to 3 days. It should be one-sided, and it should be associated with nausea, vomiting, and sensitivity to light. Next slide, please. But why do we confuse migraine to facial pain, doctor? Why do we confuse migraine to sinusitis? Now, the studies have shown that migraine normally causes headaches, and that's what everybody knows. but it can equally affect the cheekbones and also the jaw bones. So when you get pain over your cheekbones, you think, oh my God, I have sinusitis. It's so painful. So that is why people mistake sinusitis to facial migraine. Next slide, please. Next slide. And okay, so we know that migraine can manifest as facial pain. Then let us look at what are the trigger factors for this migraine. The most common ones are not drinking enough fluids, not having good night's sleep, hunger, stress, too much coffee, too much tea, too much chocolates, too much red wine, and also it can be menstrual or hormonal, and sometimes stress. So these are some of the trigger factors. So when you think that you have facial pain and you don't have any nasal symptoms, think twice, have I got migraine or have I got sinusitis? If you think that you have migraine, keep a diary and identify what triggers this facial pain. This will be very useful for you and also for the GP when you go and see them for the management. Okay, next slide, please. Now let us look at this, how this migraine starts. You get initially some mild headache. Next, please. And then you start getting some aura. You see some bright spots, some scintillating lights in your vision, and some spots in your vision. And then your headache starts getting. Next, please. And then you start getting some headaches. And then the headache slowly gets worse and worse and worse. Next, next, please. And you can see that the throbbing headache starts to come back and it peaks and then it slowly comes down. Next, please. And then it leaves you with extreme tiredness. So this is how a migraine manifests. Chronic sinusitis doesn't manifest like this. So your migrainous patient will have some aura, then headaches, and then extreme tiredness after the headache is gone. Okay, and they have a preference to go and lie down in a dark room, which I'm sure you all know. Okay, next slide, please. Now, why do we again confuse migraine to sinusitis? Because studies have shown that migrainous patients sometimes have a runny nose and a watery eye. So when a patient has facial pain with a runny nose, a layman or a common man will think, oh my God, I have sinusitis, and they go see the GP, and the GP sometimes prescribe a lot of nasal sprays, thinking it is sinusitis. But actually, it is migraine with these symptoms of a runny nose and nasal condition, which is the actual cause for his symptoms. Next slide, please. So how do we manage migraine? One, it's very easy. You keep a diary, identify all the trigger factors and avoid them, and you will feel a lot better. And then if you want to if you have a moderately severe attack, you need some treatment. And then you need some medications to prevent these migraine happening. Suppose you get migraine 3 times a month or 4 times a month. That's quite a lot, isn't it? So you need some medications. So it's a preventative medication as well. So now let's look at these treatments. Next slide, please. So for a simple migraine, let us say you have a migraine today, then you just try with simple medications like aspirin or brufen. And if it is still there, you can ask your GP to prescribe one of these triptans. I like rizatriptan, R-I-Z-A. Rizatriptan, I like that because I find patients improve much better with that particular type of triptan. But there are several triptans. Your GP can prescribe any one of these. Next slide, please. So this is for a severe migraine where you feel, I'm Mr. Ram, I want to go and lie down in a dark room. Then you can try those triptans and painkillers. But if you having frequent migraines, then you need a preventative. You don't want to be suffering 4 times a month. So you can try any of these medications like nortriptyline or propranolol or topiramate. Your GP they are very good, and they will prescribe you with one of these medications. Next slide, please. Now, in extremely severe cases where you have tried your painkillers, you have tried your preventative medications, you have tried keeping an absolute diary, and you're still suffering from migraine, then you can have botulinum toxin injection. There is a special protocol for this. The neurologist, not your GP, your neurologist, they specialize in these injections, and you will be recommended for this treatment at that stage. Okay, it requires, next slide please, a serial of injections. We can go to the next slide please. A serial of injections over the forehead and the back of the neck and back of the head, but it requires a specialist help, and the neurologists are very good at this, and they will give these injections for very, very, very severe cases. Next slide please. Next slide please. Yeah. Now, some patients will have facial pain, but they may not have all those migrainous symptoms like nausea, vomiting, sensitivity to light. But if you touch their nose, they'll be very sensitive. So that condition is called mid-facial pain or mid-segmental facial pain. It's the segment of the middle part of the face, and you get this facial pain. It's called mid-segmental facial pain. Some people, especially you would have noticed when you're stressed, maybe youngsters going for the exams, they will have tension headaches. That can also cause pain. So the treatment for that is stress management and this particular drug called nortriptyline. Okay, next slide please. So these are some of the differential diagnoses for migraine. Now let us see this interesting case. Here is a 45-year-old woman who comes to the clinic with a severe headache. It's mainly over the eye, right eye or left eye, and the pain lasts for almost half an hour to 45 minutes. It typically wakes her up in the middle of the night, and she holds her eye and says, oh my dear, my eye and my eye is so sore. I can't bear this pain. It's so severe. And he or she paces up and down, and the partner notices the eye is getting a little bit droopy and there's some redness in the eye. So they are really at the tethers of how to get rid of this pain. Now, unlike migraine, this patient paces up and down and doesn't want to go and lie down in a dark room. The pain is very severe and it is over the eye. So this condition, it occurs in clusters. So it lasts for a few weeks, goes away, and then again comes back after a few weeks. So because it occurs in clusters, it is called as cluster headache. Next slide, please. So the diagnosis of a pain over the eye, sharp and with a red eye, a very severe pain, think of cluster headache. But don't forget, you may get glaucoma as well as a severe pain. So you got to be a little bit careful. Not all things are just headaches, but think of slightly outside the box. It can be eye related. Better to see this eye specialist as well, just to make sure you don't have a glaucoma. Acute glaucoma can manifest like this. Anyway, so cluster headache is something which occurs over the eye. Next slide, please. And it typically occurs over the eye. It is severe, it is one-sided, and it occurs typically at the same time every day, and it occurs in clusters. So how do we treat this cluster headache? Next slide, please. So very rarely it can be related to some pituitary tumors, but they are not common. I've seen many pituitary tumors. I've not seen a single case of cluster headache, but it has been reported in the literature. Next slide, please. So just like your migraine, you need to reduce, or when the patient is in severe pain, what medication should I give? So that is called as abortive treatment. Okay, for an acute headache, what should I do? How should I treat an acute cluster headache? And then if the patient gets very frequent cluster headaches, almost twice a month, and it happens for the next 3 months, then you need a preventative medication just as you would treat for migraine. And in between these two, an acute pain and a preventative pain, you want to give some more medications. So what are these medications? Let's look into the next slide. Next slide, please. So for migraine, we treated them with triptans. For cluster headache, we do give them triptans, but they are not oral triptans. You don't take a tablet. You got to have either a subcutaneous injection or you can have a nasal triptan. This is the best treatment for an acute cluster headache. Next slide, please. If you go to the neurologist, sometimes they give oxygen. 100% oxygen is quite useful for treating cluster headaches. Okay, next slide, please. Now, if you want to prevent these cluster headaches from happening, because they are happening so often, these are the various medications that we use. I don't want to go into the detail, but your GP or the neurologist, they specialize in giving these special medications. Okay, next slide, please. In between a very severe spell and a preventative, sometimes they say, Mr. Ram, my pain is lingering. Is there anything you can give in between the two? You can try some steroids like this prednisolone, or next slide, please. Or you can get some nerve blocks. Again, this is a specialized, highly specialized treatment, but it is one of the good treatments that will help for patients who think they have very severe cluster headaches. Okay, next slide, please. And this is the areas where we give the nerve blocks with the local anesthetic injection and a steroid injection. Next slide, please. Now, so that case that we saw just now was cluster headache. Now let us look at this scenario. Young man comes to your clinic and he develops a pain exactly like the cluster headache, pain over the eye, sharp. The duration of the pain is not 45 minutes, but it is 20 minutes, maybe even 20 to 30 minutes, and it is more frequent. We saw cluster headaches, patients had 2 to 3 attacks a day. This patient is getting 6 to 8 attacks a day. Imagine him with a pain over his eye 6 to 8 times a day. And he goes to his GP. The GP thinks, oh, it's cluster headache, I can cure you. And he gives the subcutaneous sumatriptan, he gives oxygen, but he doesn't get better. So he goes to see the neurologist. And neurologist says, wait a minute, you're getting more frequent than a cluster headache. Let me try a different medication. And next slide, please. And that wonderful this condition is called paroxysmal hemicrania. Paroxysmal means it occurs in bouts. It affects one half of the head, so it's called paroxysmal hemicrania. So this is one form of headache, and the treatment for this is indomethacin. Next slide, please. This pain occurs just like your cluster headache, but they may have some migraine symptoms sometimes. Next slide, please. And next slide, please. And the best treatment for paroxysmal hemicrania is not triptans, is not oxygen, but indomethacin. So this is the specialists, especially the neurologists, they are very good at identifying and diagnosing paroxysmal hemicrania, and they will give you indomethacin. And within 24 hours, your headache will be cured. So if you make a right diagnosis and you give the right medication, your headache will disappear within 24 to 48 hours. Next slide, please. If the headache continues, it's called hemicrania continua, not very important. Let's go to the next slide. But the treatment is the same, indomethacin for these patients. Next slide, please. Okay, we can go to the next slide. Thanks. Right, so we have seen two types, cluster headaches, and we saw paroxysmal hemicrania. One responds to oxygen and subcutaneous sumatriptan. The other one responds well to indomethacin. Now let us look at this third interesting scenario. 38-year-old patient comes to you with a pain over the right eye. Now it's not 3-4 times a day. It's not every 20 minutes. It's almost 30 attacks. Every few seconds is happening. 30 attacks a day. Imagine this pain. And it is shooting. Like your trigeminal neuralgia, this is shooting pain, but over the eye. It is worse with cold and while washing the face, and the nose runs, the eyes are drooping. So this is a very rare condition, but I have seen a few. Next slide, please. It is called as SUNCT, S-U-N-C-T, which means short-lasting, one-sided or unilateral nerve type of pain with tearing of the eyes and the eye getting very red. As you can see on the slide on the top, the eyes are very red, as though the eye is very inflamed, and they are holding their eye, the shooting pain lasting for a few seconds, but 30 times a day. It's really painful. So this condition is called SUNCT, S-U-N-C-T. Next slide, please. And it is very similar to trigeminal neuralgia. I told you it's like electric-like pain, sharp pain, lasting for a few seconds. So trigeminal neuralgia and SUNCT are almost same, but there are some differences. Next slide, please. One, both are triggered by wind, cold, touch, and chewing. But in SUNCT, you will have watery eye, red eye. You don't see that in trigeminal neuralgia. In SUNCT, you will have the pain over the eye. In trigeminal neuralgia, I showed you he was holding his jaw, right? So the jaw pain, electric-like pain, is due to trigeminal neuralgia. The pain around the eye, sharp pain with a watery red eye, is due to SUNCT, S-U-N-C-T. Next slide, please. And the treatment is entirely different. You don't treat with carbamazepine for this, how you treat trigeminal neuralgia, but you have special medications. And these are some of the medications which requires, which will be prescribed by your neurologist. Okay, next slide, please. And in very severe cases, we can have nerve stimulation techniques, and we can even use occipital stimulation techniques. These are very rare, very highly specialized centers provide these treatments. Okay, next slide, please. So just to recap, the last three conditions I told you, the cluster headache, paroxysmal hemicrania, and SUNCT, they all have some common features. What are they? Let's look at it. Next slide. One, they all occur over the eye. Okay. Two, they are very severe. These people keep pacing up and down. They have a watery eye, their nose is congested, they have a red eye, a droopy eye. So these are common features in all these three conditions. Next slide, please. And it is jointly, they are called as trigeminal autonomic cephalgias. Anyway, I won't want to go too deep, but just want to say that these three come under one spectrum called trigeminal autonomic cephalgias. Next slide, please. Now let us see the difference between these three conditions. One, cluster headache is one or two attacks a day. This is about 8 attacks a day. The paroxysmal hemicrania, SUNCT, is about almost 200 attacks a day. The treatment is different for each. For cluster headache, you will give the nasal sumatriptan. For paroxysmal hemicrania, you know that you have to give indomethacin. For SUNCT, the special drug that we use is called ramiprogene. This is how we differentiate between these three. Next slide, please. Now let us go to the next scenario. Here is a 23-year-old female who comes to you with a pain over the jaw, the temple, and ears. And the pain is aggravated by chewing. And sometimes she says that when she's eating, the jaw gets locked. There is some history of grinding of teeth. And when you examine, the jaw is not opening straight. It is opening, it's moving off to one side. So you know that there is some jaw problem. It is not sinusitis. She doesn't have any nasal symptoms. It is not cluster headaches. It is not trigeminal neuralgia. So you got to think, is it something from the jaw? Because if you have a jaw problem, you'll have grinding of teeth, you'll have pain on chewing, you'll have trismus, which is pain, and also locking of the jaw. So these are some of the features of a jaw problem. Next slide, please. So it is called as temporomandibular joint pain. That is, it is the jaw joint. We all know when you open your mouth, you can feel your jaw joint, right? So if that is not working properly because of the spasm of the muscles around it, or if there's a wear and tear, as we see in elderly population, then like your arthritis of any joint, then you call that as temporomandibular joint dysfunction. Next slide, please. So the main symptoms that they may come to you with is pain, locking of the jaw, some pain on opening and chewing, unable to eat hard food. So the treatment is some painkillers, some physiotherapy or heat therapy, soft diet, use some soft dental appliances to reduce the stress on the joint. Occasionally, if the muscles around it are very tense, you can put some Botox injections in to relax the muscles. So these are all the treatments offered for a temporomandibular joint dysfunction. Next slide, please. And as you have the arthritis of the knee, when the knee is so badly damaged, you got to repair it and take it out and put a new implant. In the same way, if the jaw joint is so badly broken or so badly worn out, you can put a fresh joint. So it's called as a jaw joint replacement. Just like your knee replacement, we have a jaw joint replacement. Okay, next slide, please. So we saw in the last few slides about the temporomandibular joint dysfunction. But don't forget, sometimes pain over the cheek or over the jaw can come from the teeth. Always check with the dentist. You will have pain over the gums. You will notice some dental caries. So don't forget that dental cause is one of the important causes for facial pain. Next slide, please. So I want to summarize with the conditions we saw. The first case we saw chronic sinusitis, where the patient had a lot of nasal blockage, nasal discharge. The second case we saw was migraine. The second case was trigeminal neuralgia. Third case was migraine. Then we saw cluster headache, paroxysmal hemicrania. We saw SUNT. We saw the temporomandibular joint dysfunction. Then we saw the dental pain. Now let us put all these together in thing and say, if a patient comes to me with a facial pain, how am I going to diagnose? I have all these conditions. How do I systematically approach and diagnose? So you take a good history. You want to know where the pain is. Is it a sharp pain or a dull pain? And how frequent is it happening? How many attacks a day? And how long does it last? Does the patient have any nasal blockage, nasal discharge, any loss of smell? Does the patient have watery eyes, watery nose? Does the patient have any nausea, vomiting, sensitivity to light? Is the patient eating too much wine, drinking too much wine, or eating too much cheese or chocolates? Is it hormonal pain? Is it relieved with bed rest? Or is the patient pacing up and down? Or is he going to sleep? Is he or she going to sleep in a dark room? So it's a very important thing, no? You want to take a good history. Then you want to examine the patient. You want to examine the whole face. You want to examine the eyes. You want to examine the nose. You want to examine the jaw joint and look for any signs of tenderness. Having taken a good history, having examined the patient thoroughly, then you come to one conclusion. One, is this pain coming from sinuses? So if the patient has nasal blockage, loss of smell, nasal discharge, and polyps in the nose, you know that definitely that patient has got chronic sinusitis. On the other hand, if the patient says, if your examination looks normal, your nose looks normal, there is no polyps, no pus, no discharge, but you have the facial pain, then think of migraine, cluster headaches, trigeminal neuralgia, tension headache, midfacial pain. And this is how we systematically analyze why the patient has facial pain, and we treat them. So this is a very important slide. It tells you what are the different causes and how do we differentiate between all these conditions and how do we treat them. I think next slide is just references, I think. Let's go to the next slide. So I'd like to finally summarize. The diagnosis of facial pain can be challenging, but knowledge is power. If you have good knowledge, you can make a perfect diagnosis of facial pain in most cases, about 80%, I will say. So you should have a good knowledge to treat facial pain. And facial pain is not a common feature of chronic sinusitis. Okay, so remember, if you catch a cold, a sudden cold, you will have pain. But chronic conditions, especially chronic sinus conditions, usually do not cause pain. And in very complex cases, you need to have a team approach like the ENT surgeon and the neurologist and the GP and the neurosurgeon sometimes to treat complex facial pains. Next slide, please. I'm very happy to take any questions. Next slide, please. These are all references. I don't think they are very important. Okay, I'm happy to take any questions. Senta. not just it comes and goes. Number one, if the patient has vomiting, persistent vomiting, so persistent headache, persistent vomiting, loss of balance, that will immediately tell me that I'm dealing with a possible intracranial lesion like a tumor. So that will ring alarm bells. If I have a facial pain with facial numbness, if a patient has facial weakness, facial numbness, that again will put alarm bells will ring alarm bells, and I will get a scan for those patients. You may have facial pain, but you shouldn't have facial weakness or facial numbness. So, for example, they may not be able to close the eyes, or they'll say when they're shaving, they can't feel anything. That is a sinister sign, and that requires an urgent scan. Yes.
Thank you.
Vision loss, vision pain, and visual acuity, if it goes down, I will think of glaucoma. I will get an ophthalmology opinion. Yeah.
Yes, when patients are sort of waiting for their GP appointment, and if they have any eye symptoms, would you recommend them seeing an optician at the same time?
Absolutely, because opticians are also good at diagnosing glaucomas, and they will themselves pick it up and refer you urgently to the ophthalmologists. At least that's what we do in Scotland. Yeah.
Brilliant. Thank you. Thank you. One more question. You mentioned over-the-counter medication like aspirin, ibuprofen for migrainous headaches or tension-type headaches. Are codeine-based medications beneficial for facial pain or headaches?
Yes. I mean, if you are thinking like migraine symptoms, I don't have any objections of them using paracetamol, brufen, codeine. That's fine. As long as they keep a diary and identify, they shouldn't be addicted to it. They shouldn't become over-dependent, because there's an important condition. Some people, like in fibromyalgia, they keep taking paracetamol and brufen and all the analgesics. That itself can cause headaches. So people can tip over the balance. If they use so much of painkillers every day, they become dependent on it, and that causes drug-induced headaches. So just be careful with that. But use it as and when required, and then don't be dependent on it. Yeah. If you still have problems, see a GP and get the right medications. Yeah.
That was my other question about medication overuse headaches. But you answered that.
Yeah. Great. I pass. Thank you.
Okay, thank you. I mean, just to mention here for the public, again, as GPs, when we prescribe codeine-based preparation, we are very careful only them short course of medication because of the risk of dependency, and we have to also warn them about driving regulations, because if somebody drives with codeine and RDC, their insurance can be invalid.
Thank you, Sandha. That's nice.
Thank you. Any more questions? I mean, if not, is meditation or mindfulness helpful in preventing headaches or facial pain?
I think if a patient has got a stress-induced headache, like tension headaches, I think breathing exercises and mindfulness, these are some of the things which will take away the stress. It will defocus. It will give you a clearer vision, no? I think for those patients, perhaps if I have a tension, if I'm going through a lot of stress, for me, my go-to is go and sit in the altar and think of Swami. So for me, mindfulness does play a very important role in if I'm having a stressful day, I think it makes a big difference. So I suppose it is common for, I think, I wouldn't recommend for all types of headaches. For tension headaches, I think it makes a big difference. You got to make a diagnosis correctly. You got to make a diagnosis. Yeah.
Thank you. And the last question, any exercises to minimize, you mentioned the facial pain, you know, the nerve type, trigeminal neuralgia, or this jaw problems, you know, temporomandibular joint, any type of exercises people can try, or anything that you would advise, like for example, not biting on hard things, any advice you would like to give, please?
I think physiotherapy comes into picture for 2 points. One, for the jaw joint problem, temporomandibular joint dysfunction, One, they have some jaw exercises so that you don't stress the muscles around that, you relax the muscles, and your soft appliance is definitely useful. If you see the local dentist, they will give you soft appliances to reduce the stress on those joints, and their heat compression for those sort of a discomfort is quite good. For trigeminal neuralgia, I think that it's predominantly a medication, oxycarbamazepine, to my knowledge and my understanding. You probably know better because as a GP, you have more in your armamentarium than me. But for me, physiotherapy is mainly for TM joint dysfunction. Occasionally, you get trigger points. Like, for example, they'll say when they touch one part of the neck or one part of the face, the pain radiates all over the face. So for that, physiotherapy might be useful. So these are the two conditions I would say physiotherapy might be useful. Thank you.
Thank you. These kind of referrals also depends on the local policy. In different parts of the country, they've got different criteria from the CCG. Yeah. Thank you. Thank you, Dr. Ram, for your very comprehensive presentation, and thank you for answering all the questions. We hope that you all found today's session very helpful. And a very big thank you to Sister Gayatri for coordinating this webinar series. And thanks to the media team and session for all the background work you do. So thank you so much. And please join our next webinar on the 7th of March. Thank you, and Sairam.
Sairam Santa, lovely to have you. Take care.
Sairam, thank you.
Yes, thank you.
Thank you.